back, everybody, to what I think is... I should introduce myself first. I'm Chris Lavy, an orthopaedic surgeon from Oxford, just up the road. And I think this is I'm a little bit biased, but I think this is the most important session of the day. Because we've heard the data, we've had some ideas about what could be done. In this session, we say, where do we go from now? What's the action we take? Now, you may wonder why I've been chosen to chair this really important thing. I think it's because I missed the planning meeting when they were giving out the jobs. But I'm very proud to be doing it, and I'm particularly glad that it's not me you're going to be listening to. We've got a bevy of experts here, and I'd like to introduce them, but very briefly, because we're a little bit late starting, and also because after this session, it's not coffee, it's a glass of wine. And you've got in front of you the written down details of all the speakers, but I would like to introduce, before he speaks, Atul Gawande again. Very little extra to say for him, but it's all written here. Ariadne Foundation, Lifebox, Brigham and Women's Hospital, and Harvard School of Public Health, wherever that is. And on the table, we have Bob Lane, whose potted biography is on the sheet. Bob has been the chairman of most of the important surgical organisations in the UK, and continues to be very active internationally. But his main training occurred when he was my father's houseman a long time ago. Jaymie Henry really is a film producer, and we're really looking forward to hearing what you say, and in particular about the G4 Alliance, this alliance of many surgical societies, universities, NGOs that Jaymie and others have brought together to really push forward global surgery. So it's lovely to have you here, Jaymie. David Brash from General Electric. I've not met him before, and we had a little chat just now, and you can read all about him on the bio. But General Electric is a company that is really taking global surgery seriously with the programs that it's doing. And if anyone else here from other branches of industry, meet him afterwards and see how your industry could start to take global surgery seriously. Julian Gore-Booth from the World Federation of Societies of Anesthesiologists. Some of the anaesthetists were complaining a little bit earlier on that they didn't get enough representation, but we've now got their chief executive from the World Federation of Societies of Anesthesiologists. So great to have you here and bring up anesthesiology, because we do need you. And last but not least, Chris Whitty works currently as Director of Research and Advisor for DFID, our own government. So we've got someone from our own government here to harangue here. Chris, fresh in from Nepal. You can catch him and ask him about that later on. Chris has done many things in his life, and we first met at a poetry evening in Malawi. But now the last of the stragglers has come in, and I'd like to ask Atul to take the podium and speak. Thanks, Atul.
Thank you all for hanging in today. It's been a really energizing, unbelievable day. The Lancet a few weeks ago asked me to try to write an essay that came out just today online, taking a look at the findings that have come out of the Lancet Commission and trying to combine it with the real experience that people have on the ground and point a direct and try to see what it says about what we should be doing. This was a rather complicated assignment, especially since they said I had to do it in under 2,500 words. But the way I went about it was deciding to take a look at the community where my father comes from. My father is from Maharashtra, a central state in India. He's from a rural village. He was one of 13 brothers and sisters. They grew up in a rural village about 400 miles east of Mumbai in a district where the major crops that my family raised and still raise to this day are cotton, a grain called jawar, and sugarcane. And that was how they made their living. My father ended up becoming a surgeon himself and settling in a small town in Ohio where I was raised. And what I did was I called back to my uncle, who was a family physician there, and I said, "What happens when you have a surgical patient?" And he put me in touch with someone I had not met before on my previous trips there, to my surprise. But it is a physician named Shrikant Jaiswal, who is the first anesthetist for this community. He is just 34 years old, and I realized in this one person, you could see the entirety of what we were describing in this report. He is the anesthetist for a town of 60,000 called Umerkhed. Around Umerkhed are 100 villages with a population of about 250,000, and they have a first-level hospital there. That first-level hospital has 30 beds. It has a maternity ward and very, very basic surgical facilities. But those surgical facilities largely went unused until 6 years ago when Jaiswal arrived as a young anesthetist. Until then, they had 2 obstetricians who did whatever surgery they could. So they did not have an anesthetist, and that meant if somebody had an obstructed labor or was hemorrhaging, they sent them on the road 2 hours away, 70 kilometers, to the nearest next level hospital that had capability to help. Under local anesthesia, however, they would do tubal ligation, they would lance abscesses, they would take care of more localized kinds of problems, removing superficial tumors. They also did vasectomies. They did whatever they could with the need that was there, but otherwise it was limited. I asked Jaiswal why he returned. He was the son of a government clerk in the local city government. He had done well in school and got an admission to university in Mumbai. So then he went back to his rural town and asked him why. And he said as he was coming to the end of his studies and his training in anesthesiology, his father developed chest pain. A family member called him, and he racked his brain. He was having a crushing chest pain. And he said, "I could not think of anyone who had an ECG machine and knew how to interpret an ECG machine and treat whatever was found." He returned home as quickly as he could. His father recovered, but 6 days later, his brother-in-law had a heart attack and died. And he said he needed to return because if this was what was happening to his family, what was happening to all of the other people he grew up with? It also brought home the power of couples. Nobajit Roy mentioned that his wife is an anesthetist, and it was exactly this that allowed them to create a little surgical ecosystem, because Dr. Jaiswal's wife, Preeti, is a obstetrician gynecologist, and the two of them could kind of be a team together. That allowed them to return. Their first struggle is how to make a living. He said that the government posts, and other doctors told me this, pay 1/4 of what people would make in a modest-sized city in the private sector. And so they set up shop trying to do a mix of government, public, and private practice. In that setup, because he was there as an anesthesiologist, shortly thereafter an orthopedist came to provide open fracture care. And then he found that he was doing about 2 cases to 3 cases if it was a good day, 3 cases in a day. The most common procedure was emergency C-section. The second most common procedure, open fracture. Now, in order to maintain what he felt would be adequate income and a busy enough practice, he felt he needed about twice the volume that he was seeing in practice there. But an interesting thing happened along the way, and I think it reflects one of the things that we have commented on, the idea that the existence of surgical capabilities increases capacity in a place. And the interesting thing was that because he was somebody who could take care of a sick surgical patient, people began bringing him sick, complex patients of all kinds. They would come knocking on his door with someone with chest pain having an acute MI. And so he decided, well, I have to get an ECG machine. He figured out how to obtain streptokinase. TPA was too expensive, but you could obtain streptokinase for relatively inexpensively. He got a hold of dopamine and dobutamine and amiodarone, set up a kind of makeshift ICU bed on the first floor of his house, and he could treat heart attacks. In the last 6 years, he's treated more than 300 acute MIs and says he's had a less than 3% mortality rate, where previously the only option, forget the golden hour, was a road trip 70 kilometers up a rutted rural road. He also saw large numbers of an unexpected public health problem. 1 out of 5 traumatic injury deaths in India, especially in states like Maharashtra, are in fact from snake bites. And people began coming to him for snake bites. For snake bites, you need to give antivenom and you need to give respiratory support. They're neurotoxic. The crate and the cobra are neurotoxic, and the villagers who sleep on the dirt floors at night, especially during monsoon season, would get bitten. And so he's treated more than 600 of these snake bites. And he gives the antivenom by being there. The government hospitals are supposed to have stocked the antivenom. They didn't. He agitated for it, and they stocked it. It's too expensive to buy otherwise for the villagers. He would give the antivenom, and then the patients would go into respiratory paralysis, and so you would have to intubate the patient. They had no ventilator, no oximetry, and so he would just have the family use a self-inflating ambu bag and ventilate the patients at a counted rate that he would tell them to count how many per minute. He said the families are better than the nurses. They never get tired. They would have to keep their family member intubated, typically 2 days, as long as 1 week he's had them maintain their care. This is what the capacity of a single capability allows in this kind of area. I asked him what would most improve the surgical services in this area, and it echoed exactly this report. He said, number one, they would have better safety and quality procedures and equipment. If he had an oximeter to allow the families to know whether they were bagging at the right rate to keep people alive, or if he himself was able to have that in anesthesia to know how to regulate his anesthesia, it would have made a huge difference, he said. They were bringing the 19th century to the 21st century. Anesthesia was discovered in the 19th century, and so was antisepsis. And antiseptic precautions were very poor. He saw very high rates of infection. And what Kelly McQueen had said about that focus on the safety of the patient, he felt he had to agitate with the surgeons to have basic hygiene, and wasn't achieving it because the basic protocols still weren't there for, hand washing with something other than soap and a towel, but actually antiseptic solution, using proper antisepsis and sterile drapes, gloving and gowning, not with reused gloves, and so on. The second thing he said was They needed a general surgeon. They had the obstetrics, they had the fracture care, but people would come with a ruptured appendicitis. They would come with a gangrenous gallbladder. They would come with typhoid perforation. They eat a lot of hot chilies in this part of Maharashtra, and the rate of duodenal ulcer perforation was exceedingly high. I'd been in this place, and you would see a duodenal ulcer perforation about every other day, unbelievably. They needed a general surgeon, and my family knew this. My uncle, my father's younger brother, crashed his motorbike. He's a farmer there. He was in his early 50s, and he had a pelvic fracture. He had a massive hemorrhage, a long bone fracture. He was in hemorrhagic shock, and what he needed was basic trauma care. They knew they could not provide it. He was put on that road to the next city, to the city up the way, and all we could do was pray for him. And we were just extremely lucky that he survived. It would have meant financial catastrophe for his family. He was the inheritor he was the key breadwinner for the extended family in our village. Only the larger cities in lower and middle income countries have enough prosperity to sustain surgical services when people are paying for it themselves. The next level hospital from Umerkhed is a town called Nanded, 70 kilometers away. It has 600,000 people, serves an area that has about 5 million population that come for care. And the surgeons I speak to there think, no data, think that that about 40% of the population has enough money to pay for their services. 60% do not. But that's enough that over the last 20 years, there have now come 65 surgeons and 60 anesthesiologists in that community. 40 general surgeons. There's 3 neurosurgeons, 2 pediatric surgeons. The capability started to appear. For the 60%, there generally has only been that government facility there. And in that government facility, only 6 general surgeons and 8 of the anesthesiologists were willing to practice. The pay was too low. The bureaucracy was often infuriating. The political risks could be high. And they had great difficulty just with the operations of being able to make the time productive, and many decided it wasn't worth the frustration. So I've been there and seen the throngs. They could have anywhere from 300 to 500 people coming for your morning surgery clinic. And unbelievably, between them and the medical students and the residents, they would see maybe 40 to 60 people in an hour, which meant that there was almost no exam, just you go here, you need x-rays, here's some medicine, I think it's worms. There's been a change, however. 5 years ago, the Indian government passed a program called RSBY, which are the initials for the Indian word for National Health Insurance Program. And it's a program for people below the poverty line that allows you to buy for 30 rupees, which is about 50 US cents, 30 rupees a smart card that allows you insurance in a private or a public sector facility up to 30,000 rupees in costs. It covers hospitalization, and it covers essential surgical procedures. 25 states have rolled it out. There have been 37 million people who've bought that card, and more than 25 million of those people have used the services. And you could see the difference in that community, because virtually all of the surgeons and anesthesiologists accept that card. It pays less than they typically charge, but they have availability, and so they honor the card. And a group of them have begun to cater specifically to the poor who carry that card. It's no coincidence, I think, that you've seen the financial viability of surgery in this community, to the point that, the way the surgeons practice in that community is Generally, you have a one-person hospital. You set up your hospital in your house. You have an operating room and 3 or 4 recovery beds. But 3 of the surgeons now feel they have enough business that they've got together and started forming a large group hospital together. And this could be how systems change. There's an essay that's, for me, the foundational essay of the work I've been doing that I read when I actually got to spend some time at Oxford studying philosophy. And it was an essay by the philosophers Samuel Gorovitz and Alistair MacIntyre. And they were writing about what the nature of human fallibility is. Why do we fail at anything we set out, at some things that we set out to do? And what they pointed out was there are 2 core reasons why we fail. Ignorance, meaning the knowledge does not exist, or what they called ineptitude, what I'd call more nicely the failure to deliver. The knowledge exists, but we have failed to deliver on it correctly as individuals or as groups of people. And where we are is where we don't know exactly how to change. But the report, I think, gives us some glimpses of how. And I could see those glimpses in understanding that there are many countries that are making this transition from very poor to starting to have capabilities that allow the sustaining of surgical services. Every country that has been high income was low income at some point. In my hometown in Ohio, we got our first obstetrician in 1968, and I don't think it's a coincidence that was 3 years after the passage of our version of RSBY, the Medicaid program, in 1965 for the poor. We had no anesthetist in the community, so a family doctor provided drop ether as an anesthetic at a time when it should have been historically, only of historical knowledge, but did that through the early 70s. 1973, my parents arrived, my mother, the 3rd pediatrician in the area, my father, the first urologic surgeon, and he did some general surgery, and it was a community of 250,000 in the surrounding rural area, the poorest county in Ohio. We got our first physician anesthesiologist in the 1980s, ironically an Indian that my father helped recruit to our community. The US, at the time we adopted that insurance program for Medicaid, was at $20,000 GDP per capita. India adopted its program at a time when it was under $1,000 GDP per capita. Korea, which made the transition India's undergoing from very rural, limited facilities, only decent surgical care in Seoul. But in 1977, when they were at $3,500 GDP per capita, they began mandating that large businesses buy insurance, and they brought insurance for the poor in the 1980s. During that time, they went, as India seems to be undergoing, from small, private, very rudimentary, often unsafe hospitals to larger group hospitals and an infrastructure that could support it. Their major problem today is now the opposite problem, overuse of surgery, and they still have issues with quality and safety. Many countries have transitioned. We have not mapped how. The knowledge exists, but we don't know it. We are still in the phase of ignorance. But in other areas, we are not. My institution and myself joined with the World Federation of Societies of Anesthesia and the AAGBI, Association of Anesthetists of Great Britain and Ireland, in 2011 to form Lifebox, focusing on safe surgery globally. We were taking the WHO findings that we'd been part of to create a safe surgery checklist as a basic set of how to make safe anesthesia, infection reduction, adequate teamwork and communications to improve survival in surgery. We found that even in high-income countries, you could lower the death rates by 1/3, and in the lower-income countries by half or more by implementing the work. And we've begun supporting that rolling out in the low and middle-income countries. We've been able to do that by focusing on lowering pulse oximetry costs, getting it down to less than 80% for poor communities of what they were otherwise paying. We've focused on finding owners of quality of at least safe anesthesia as the first starting point. And the anesthesiologists were like Jayswal, they were willing to do that. And we distributed more than 9,000 oximeters to them as the owners, and that's helped stock more than 9,000 operating theaters around the world with this basic safety capability, to the point that now we've also trained 3,000 anesthetists, anesthesia providers, and seen the safeguarding of now more than 10 million lives in 90 countries with a team of just 4 people helping to make it happen through the incredible networks of these organizations. We're now trying to develop and test the approaches to taking that way of making safe anesthesia to how to make safe antisepsis and surgical infection reduction. What struck me talking to Dr. Jayswal is, here I am working with Lifebox, and in my own community where my father's from, we'd failed to make it happen. So I sent a check for $250 to Lifebox, actually $750, got him 3 pulse oximeters, 1 for him in his own hospital, 1 for the operating theater in the main government hospital, and 1 for the recovery room. And he said it would make a difference, but they had a long way to go. He told me about an experience on the phone that I think brings it home. He called it my very horrible experience. The day before I'd spoken to him, a 12-year-old had fallen out of an ox cart and then been run over by it with a blunt chest trauma. Arrived, and the orthopedic surgeon was the one who saw him in the government hospital, called Jayswal because the boy was blue, didn't know what to do. He had obvious rib fractures, listened to his chest, no breath sounds on one side, tracheal deviation, he had a pneumothorax. But there was no needle. There was no 18-gauge needle just to be able to release the pressure, let alone a chest tube. He sent a friend to grab what he had from a private hospital supply, his own supply. Waiting those agonizing minutes, they finally came with the needle and he plunged it into the chest, and you started to get some breaths again on that side. Then they found a chest tube in a private stash, and that chest tube, he'd never put one in before, at least one time he had as a student. He did the best he could, made a slash in the chest, jammed it in, 400 cc's of blood came out, and thank God, he said, it stopped. He had breath sounds. And then he listened, and on the other side now there was no breaths. And he had nothing he could do. He put him on the road, called a friend up in the next town, and said, I hope you'll take care of him. They don't have any ability to pay. The next day, the friend said he did, and the boy had survived. He said, we have a desperate need here. And I think we've just learned what the next steps are. And our job in the next couple of years is to begin showing the steps. I think we have to map the transition of the countries that have made this leap. Somehow, Korea did it before, well before the US, getting universal coverage at under $10,000 GDP per capita. And India has already made a program for the poor where they're at about $1,000 GDP per capita. And what programs work, what programs don't, what the features are, those can be mapped and they can be described. How to cope with corruption, these are essential problems and needed for the policymakers to believe in it. But we know how to begin mapping that. Number 2, we have to measure the metrics that were described here. We can do it by starting at a state level somewhere. Start with one place first. Move to a country level. We can move to the regional level from there. Number 3, we have to build the demonstrations to work out the steps for building the infrastructure. It's not going to be enough to have the surgeon, the nurse, the anesthetist. We need the manager, the leader who is willing to own making a functional surgical system and put it together. That could be a hospital leader, it could be a surgeon, an anesthetist, a nurse, but one willing to hold the team together and then foster, coach those managers to start with their existing infrastructure which currently has a very low throughput, maybe 2 operations in a day, we can double that in the existing infrastructure. And we can see the infection and death rates drop with some of these basic safety protocols. We still have a lot of ignorance about how we make it happen, but filling in these basic gaps will make that happen. And I think there is relatively little ignorance about the 4th component, which is insurance for the poor, pooled prepaid care through tax mechanisms or other mechanisms, but insurance for the poor. As Jayswal said, we have a desperate need. And then he said, I suddenly have to go. He had an emergency C-section to do. He said, maybe we can keep discussing this another time? Thank you.
Thank you very much, Atul, for answering that in a way that I think we weren't expecting. I think we had maybe thought we were going to talk about policies and governments, and indeed you did. But you also brought in the fact that it's individuals, and it's individuals like Jayswal that are really going to answer this issue of global surgery for us. Thank you very much, and we're going to bring you up to answer questions at the end. And I'd now like to turn to our group, and we're going to use the order in which we've got you here to ask you to speak for a few minutes on this whole area. Now, our time's running away with us, and so my mobile phone is going to bark at you if you go beyond 5 minutes. And Jaymie, first of all. Thank you, Jaymie.
I'm going to go fast then. So, respected colleagues, friends, it is my great privilege and honor to be invited to comment on the Lancet Commission's findings from an advocacy perspective. And I come from a low and middle income country myself, so it's really from the heart that the message is coming from. But in my capacity as the Executive Director of the Global Alliance for Surgical Obstetric Trauma and Anesthesia Care, the G4 Alliance, which is a network of 40 major surgical obstetric trauma and anesthesia care organizations, representing over 200 organizations with a global reach of 140 countries, we would like to commend the Lancet Commission for an excellent review in summarizing the current knowledge of the field of global surgery. We would also like to commend the extensive consultation that the Commission has undertaken with over 100 countries, really learning the perspective on the ground, which is very important to us. Dr. Leather already mentioned the missed calls for action for over 30 years, and today we're very excited because there is an opportunity for us not to miss this one. Today we have heard of compelling statistics, which I'm not going to repeat, but we now know it translates to an enormous amount of human suffering and economic loss at a global level. It is without question that this is an issue of global concern. So what can we do from an advocacy perspective? Let me start by mentioning that we should learn from history. The establishment, for example, of the Millennium Development Goals led to the acceleration of political, social, and economic support of several high-profile global initiatives, such as the Global Fund to fight AIDS, TB, and malaria, the Presidential Emergency Plan for AIDS Relief, or PEPFAR, and the Gavi Alliance for Vaccines and Immunizations came out from this. As we now know, tremendous gains have been achieved in decreasing deaths and disability from these major global concerns. In the same way, for global surgical care to succeed, we need major commitment from major supporters and funders. We need major advocacy. So what are the 2 key challenges of global surgery? The first one is effective framing of the issue, which the Commission has been amazingly good at, and we're very happy about that, because then we can move on to the next key challenge, which is defining concrete next steps for which the path forward is laid out in very specific terms. With the launch of the Commission report, as well as the Disease Control Priorities 3 report on surgery, substantial knowledge and estimates of the burden of disease, access of surgical services, and the volume and distribution of surgical procedures have been established. Metrics to track safe surgery and anesthesia have been proposed. The springboard for action is prime. To claim surgery's rightful place in global health, however, we need to translate the recommendations of the Commission and other major reports into a roadmap, a clear plan of action that includes the support and engagement of all the stakeholders in global surgical care and in global health in general. We need to align everyone's efforts and leverage each individual or group's experience and resources. We need to map the political space, as mentioned earlier. We need to identify what are the key early wins that we are going to go after as a whole community. And we have to establish our credibility as a group that we can all work together and we can all establish independent accountability frameworks. We have all the commitments that we are putting forward together. We need a multi-pronged advocacy strategy. That means that we bring the message to everyone, everywhere, all the time. And how do we do this? At the global level, major campaigns for societal funding need to incorporate surgical care from the vantage point of the human right to health, strategies for economic and social development as a means of poverty eradication, gender equality, and access to adequate reproductive services. As such, political engagement by the global surgical community is essential in order to highlight the role of surgical care in addressing these issues. For example, Dr. Charan has asked me, do you know how many countries actually have surgical care in their national health plans? We don't know exactly the number of countries, and that's something that we can go after pretty quickly, really early, and we can start opening that discussion. As part of any global campaign for surgical care, it will be critical that advocacy efforts focus on engaging national governments, multilateral organizations such as the WHO, the UN agencies, World Bank, major global health funders, and civil society. Moreover, implementation plans and ongoing commitment from all stakeholders are critically important, particularly at the country level. The need for cooperation both within the surgical community and with the global health community cannot be underestimated in clearly framing and communicating the issues and priorities in global surgical care. Strategic partnerships between the global health community, civil society, and government will be critical to ensuring long-term commitments essential for success. And generating a strong and unified voice will help disseminate our message to the broader global health community, policymakers, and to philanthropic organizations. Lastly, overcoming these key challenges provides the potential to substantially move the issue of global surgical care from commission to action. As the world looks towards the age of sustainable development and the 4 other transformational shifts, the surgical community must not miss this critical window of opportunity to engage and advocate for universal access to safe, affordable surgical and anesthesia care when needed. Thank you so much.
Thank you, Jaymie, and we look forward to asking you questions as well and hearing more about G4 Alliance. David.
Thanks, Chris. First of all, I want to say I'm not afraid of dogs. I love dogs, but I am allergic to cats, so you're going to have a meow on there if you want me to.
I need a teenager for that. Yeah.
The first thing I want to do is settle an argument. I'm an emergency physician, which is, I think, in my bio, but Chris didn't mention it. So I was going to say that the guardian of the patient's safety is emergency physicians, actually, as opposed to what others were saying. But actually, the truth of this, as we all know, is it's actually nurses. And I think we ought to acknowledge the fact that as much as the physicians really want to protect the patients, it's really the nurses who do it on a day-to-day, hour-by-hour basis. So I'll settle that argument amongst the physicians and say it's none of us, it's the nurses. First of all, congratulations to the Lancet Commission, John and Lars and Justine and the rest of the team, and Andy and the rest of the team for an extraordinary output and program here today. It's been wonderful for us to observe it and be part of it, and I think the output from that, from an industry perspective, I have to say I'm in awe of what you've actually accomplished, so congratulations on that. I also want to thank the Lancet Commission for including industry today. I think the problems we've seen today, or the data we've seen today, put in front of us some really complex problems. And in order to solve those problems, we're going to need partnerships. And in my view, those partnerships will need to include industry. It's not just GE. Actually, by the way, how many other people from industry are here? I'm just out of curiosity. Good. So there are some others here from industry. And it's not going to be just GE, General Electric, or the GE Foundation. There's going to be others that are going to have to participate in this initiative and partner with NGOs, partner with academia, partner with ministries of health, partner with clinicians to be able to make change here. And in those partnerships, our view is you have to take these complex problems and really deploy simple interventions. It's not about looking at the complex problem and trying to tackle the entire thing. It's really important to, and we know this as many of us are clinicians, we know this. If you have a complex patient, you need to break it down into the simple interventions, whether it's antibiotics or a pulse ox or some other intervention, you have to take it step by step. The second thing, which Atul mentioned, and we've talked quite a lot about, is leadership and management. This will never be sustainable unless we include leadership and management. And as a representative of industry, I know this is really important to us. GE prides itself in its leadership training and what we do from a leadership perspective, both from a commercial perspective, but also from the way we train the future leaders in industry. And it's going to be really important that we focus on industry as an element here. Why does this matter to industry? Why am I even sitting here? And I want to say that what we're doing today around health and global health is really important for global development. There are various ways you can look at this, whether it's education, health, and infrastructure, whether health is the most primary, whether education is, whether infrastructure is. It doesn't really matter. It's really a triad of problems that need to be addressed. And as a global company, we know that we need to invest in global development in order to be successful. It's part of our corporate social responsibility to be investing in global development. In fact, our GE Africa team, so GE has a tagline that's building a world that works better. Our corporate social responsibility team in Africa took that and took the Swahili word kujenga and built their corporate social responsibility around what we call GE Kujenga, which is to build, which is to develop globally, which is to put those pieces in place that are going to allow economic growth, allow health, allow education, allow infrastructure to grow. It's about empowering people with education and skills. It's about empowering communities, sometimes with equipment and infrastructure. And it's about elevating ideas and advocating for the things that we need to do that are the right things to do. And the last thing I want to add to that is that it's really important that we think about, these are tough things to do. You know, GE is a company, and this applies to a lot of people in industry, but we really want to do the tough things. Edison said, I figure out what people need, and I invent something to fix the problem. I think it was Dr. Reddy earlier who said, I want to perfect the possibility. I think that's, or the possible. And it's really important to think about doing these very, very tough things. Larry Page says, I have a healthy disregard, the founder of Google says, I have a healthy disregard for the impossible. I think it's important for us to be able to think that way and be able to tackle some of these problems. The other reason we do this is that, quite frankly, it makes economic sense. When you see $12 trillion loss of economic productivity, as an industrial entity that's a global company, it's important to us that we try to fix that problem. And so if we can be actively involved in safe surgery to try to address that loss of productivity, it's a good thing for us to do as a company, but it's also the right thing for us to do. So we want to be very engaged in this, and we want to be very much part of how we help solve this problem. The other thing is, as an industrial company, we don't want to do little things. We're a big company. We want to do things that are going to make exponential change. So it's important for us to be involved in this, not so that we can help be incremental. Uh-oh, I'm really far behind. I'll leave it at that. I'll take questions.
I'm not going to stop you.
Yeah, you can go ahead and meow if you want. But I will just say, there are lots of examples of where we've already done this. We're training nurses in anesthesia in Western Kenya in partnership with Mark Newton, who's here in the audience, and Kajabi Hospital. It was mentioned earlier that we're training biomedical technicians to maintain and fix medical equipment so we don't have the junk for Jesus phenomenon that was mentioned earlier today. We're building oxygen plants in Western Kenya and northern Rwanda so we can deliver oxygen where it's needed. Those are the things we're starting to do. We're hoping to wrap this into an ecosystem where we can be impactful and helpful, and I'm happy to take questions afterwards. So, thank you.
Thank you. Thanks very much. And Chris?
Firstly, a disclaimer. Like all chief scientific advisors, I'm independent, so don't assume that what I say reflects the government. And in fact, during the election period, no civil servant can speak for the government. So this is the view of a person who works in government, not of the government, just to be clear. My first bit of research was in 16th century medicine, and it was actually about the battle between the surgeons and the physicians, who spoke different languages literally at that stage. It was fantastic training for the discussion that usually happens on this subject, which I've come across through my entire career, where you have surgeons talking about individual patients and need, and you have public health people who people government generally, talking about opportunity cost and the number of people you can't do if you do this. And the two conversations are completely in parallel. Both groups get incredibly pompous and say they're the people who are advocating for the patient. Very unhelpful, and the first reason I really welcome this report is it speaks a language both groups can understand. And that's fantastic. Minor caveat to that, always be careful if you're going to quote any kind of numbers in terms of cost effectiveness that it doesn't ever sound like advocacy. Policy people read advocacy numbers on cost effectiveness with the same enthusiasm that clinicians read drug company data that very strongly skews to make their product look better. It immediately means you're not trusted. I don't think it happens in this thing, but I think what you should do is be very careful we don't slip too far into the advocacy thing. The second thing I enormously welcome is the fact that anesthetics is here, even if it's silent in the title. The first major bit of research that I actually was involved in was run by a fantastic anaesthetist called Paul Fenton in Malawi, where he did an enormous survey of caesarean sections for about 9,000 patients. And what that clearly demonstrated is the reason the mothers died and the reason that the neonates died was because of poor anaesthetic care, not because of poor surgical care. Getting surgery and anaesthetics together, absolutely essential, so enormously welcome. So I wanted to make 3 points. The first one is there is often a false dichotomy, and we must be careful in translating this excellent report, we don't slip into it, between those people who say we should do lots more surgery and people who say no, surgery isn't relevant. Both positions are clearly untrue under certain circumstances. There is a ladder of need. If there is no surgery, we need some very basic surgery first. If there's basic surgery and the resources allow, then slightly higher surgical training for particular things. But start from where we are and gradually move up, rather than try and say surgery or no surgery, because I think that often leads to a lot of misunderstanding and unhelpfulness. The second is there must be a realistic understanding of timescales. Training people to be surgeons, training the teams around them to support them to be surgeons, training anaesthetists takes a long time. And we need to build that in and be serious about how long that is going to take, rather than assume that somehow it can be magically out of thin air. It cannot. And the third thing I wanted to say was something about opportunity staff, and this is my last point, opportunity costs of staff. Getting more people to do surgery, getting more surgery in India or Vietnam, which have got a very large number of trained people who either are medics or paramedics of some form, the opportunity cost is very low. If you're talking about even a country like Ghana, which is a middle-income country now, you're talking about a very small medical profession. Every surgeon who is a surgeon is not something else, and that balance has got to be got right. If you're talking about someone like Sierra Leone, where there are only 2 doctors per district, arguably one of the issues that didn't help us with the Ebola outbreak recently, then actually taking one of them to be a surgeon may not be the right answer. So we have to be sensible, both about the amount of money, but also about the human resource there is in countries where the education systems, both basic, primary, secondary, and tertiary, are incredibly weak. And we must keep that always in mind. Thank you very much.
Thank you, Chris. And the dogs are on the leash still. And Julian, I'd like to invite you to speak now.
Thank you, Chris, and thank you, Chris, for mentioning that surgery and anaesthesia thing. We're very appreciative. When I say we're very appreciative, perhaps I should let you know that I'm not an anaesthesiologist. And when I came into the World Federation of Societies of Anesthesiologists about 18 months ago, there were some health messages and facts that really shocked me. It seemed absolutely incredible to me that I might be almost 1,000 times more likely to die from complications related to anesthesia in parts of West Africa than I would be in parts of Europe or the States. And then when I started to try and unpack a bit what that meant, I realized that that wasn't just an issue around safety and quality in the operating room. It was an issue around access, that people were simply arriving at the hospital already incredibly ill, and they were not giving the surgical team much of a chance at that point. And that has those issues, safety and access, have really fired me up. So I'm incredibly fired up about the Lancet report, and I think also the context that sits in, which is that 2015 is an extraordinary year for surgery and anesthesia, with DCP3, with the Lancet Commission, with the World Health Assembly. We hope for resolution on strengthening surgery and anesthesia. This really is an extraordinary year. We've got a way to go on the Sustainable Development Goals, which seem to persistently want to ignore this area, but there is hope. And I think that the Lancet Commission report is going to help us enormously with that, because these are very powerful messages. So what might the strategy for anesthesiology be? Well, the good news is that we do know the state that we want to achieve. So when we're talking about universal access to safe, quality, and affordable anesthesia, we do have we do have something called the International Standards for a Safe Practice of Anesthesia. Now, these were last published in the Canadian Journal of Anesthesia in 2010. They are reviewed on a regular basis and will be republished again shortly. So you can find these on the website, but the point is that the definition of the state is there. So when we shout out, what do we want it? What do we want? Safe anesthesia, and when do we want it? Now. We know what we're describing. Of course, the now bit is a bit more difficult. It is a function of three main areas. It's a function of people, it's a function of drugs, and it's a function of equipment and infrastructure. So if we can measure those things, and we know where we want to get to, we're actually defining the task, which I think is part of the question that we were asked to answer. So we are engaged now in a manpower or a workforce survey that looks at anesthesiologists, both physician and non-physician providers, their level of qualification and education, and what is available around the world. I think that's a key piece of work. It needs to be repeated for drugs, and it needs to be repeated for equipment and infrastructure. So the work of WHO, ourselves and others in looking at these three key areas of a safe anesthetic are extremely important. Once we've mapped the gap, then we're looking at filling the gap. I think there are a lot of commonalities around how people think that might be done, and the report talks about education and training. It talks also about other areas. We need to talk about innovation. We need to talk about research, and we need to talk about advocacy. Filling the research gap is as important as continuing to do research in and from high-income countries. It is extremely important that we're able to not just find data from low and middle-income countries, but that data should be coming from researchers in low and middle-income countries. One of the ways that you can do that is to build connections between esteemed medical journals, traditionally in high-income countries, and researchers coming from low and middle-income countries. And again, that's something that we are actively doing and would like to do more of. The core to a lot of this on the education side is, I think, about standards and protocols and guidelines. I'll finish with three key messages. Sorry, four. I think there may well be such a thing as essential anesthesia for essential surgery. I think that anesthesiologists do make very good perioperative physicians. I think that a lot of the solution is about partnerships. We are, a lot of us, auxiliaries to government. We are also auxiliaries to patients. We're all about patients, and we need to be talking to patient groups. But we've got to convince governments if we are to really change the global health budget, and I do come back to money.
Julian, thank you very much. And Bob, we've specially selected you to be last.
Yes, the least should be last, yes. Thank you very much, Mr. Chairman. I shall keep the time. I'd first like to thank and congratulate all the authors of the report. I think it's a fantastic achievement, I really do. I've been asked to talk a little bit about the high-income contribution, high-income country contribution to surgical training in low-income countries. And I should confine my statements really to Africa, where all the low-income countries, bar 3, happen to reside. I can't talk more than 5 minutes, so I'm going to confine most of my comments to short-term training commitments. And I suspect many of you in the room will have participated in missions of some sort in Africa in your time. Some of them not quite so successful as others. And over the years that I've been involved in this, I've learned a few tricks of the trade. The first is, if you're going to contemplate having a partnership, and I suggest a partnership, it needs to be with, in Africa, in West Africa, with the West African College of Surgeons, or in East Africa, with the College of Surgeons of East, Central, and Southern Africa. Because your contribution depends upon the need of the country you're going to. You don't decide, I'm going to run a hernia training course in X and go out and do it. Because somebody may have been there 1 month ago and done the same thing. So there must be cooperation and coordination. And believe you me, I've known guys, 1 week they've had a hernia course, and the next week they've had 2 other guys going out and run a hernia course. So you do need to organize these things properly. You must always keep the stakeholders in the picture. That includes the ministries of health. They're entitled to know that you're coming from outside, and usually north-south divide, and what you're doing. And this can be beneficial to you as well. The content of the course must be decided between you as partners, but of course it must be appropriate for the needs that you've identified, and the procedures must be relevant. You can't simply transplant a course in the UK, fly it over to Africa, drop it down, and just carry on as before, because it won't be appropriate. They will not have MRI scans or hundreds of CT scanners and things like this. Whatever you train must be appropriate, and the equipment must be available in that country. Now, the advantage of running short courses is that you can train a large number of people to the same standard at the same time, without really knowing and understanding their previous level of experience. So it's quite a win-win situation. Over the years, it has become far more important to run trainer-trainers courses up front of trainee courses, because everything that you do, everything you introduce in a training mode must be sustainable. There's no point in going out there, having a fabulous course, and then it finishes, because nobody else can carry on when you go home. Some people say to me, what happens if you go to a Francophone country and you can't speak French? Well, there is a slight problem. There are ways of getting around this, and I know you will laugh when I say this, but you can speak English with a French accent. And I have, with success. But training trainers is of vital, imperative importance. Now, who to train? Is it just medically qualified doctors, or should it be non-physician clinicians? Now, this, of course, depends on which country you're going to. Some countries in Africa do not see the need to have non-physician clinicians doing surgery. Others have no choice. And this is what you must discuss, not necessarily just with the colleges, because they may not be all that interested in training non-physician clinicians to do surgery. The ministries of health may be more compliant because they see the need. And I can tell you that NCPs, non-physician clinicians, are, as you can appreciate, just as intelligent as medically qualified people. Just as intelligent. It's just that they never had the opportunity to go to secondary school, let alone university. And we have taught both on the same course, and you could not tell who was who. Now, I'm not going to go into all the ins and outs otherwise. I just come on to outcomes, because if you are running courses and you're being paid for, say, by government grants, when you get back home, they don't care where you've been, what you've done, how you've done it, when you've done it. All they're interested in is outcomes. Okay, Mr. Lane, what actually have you achieved? You've trained N number of trainees. How do you know that that's done any good? And the answer is you have to have a quite refined assessment, monitoring and evaluation system so that you can actually answer those questions. I haven't got time to go into that now. All the courses should be fit for purpose and value for money. Finally, I'd just like to say one other contribution, and that is towards information technology. I am probably the last person in this room to talk on this subject, but I do understand the enormous potential for training purposes and, as we've discussed already this afternoon, to gather and capture information and data, because that's what we desperately need. So, I thank you.
Thanks, and thank you, Bob, very much. I brought Atul back onto the stage now, and I'm going to invite questions. And I do apologise, John, if we slightly eat into your closing remarks. Yes, man.
Yes, I was wondering.
Do you want to speak into the microphone so that everybody gets the question?
Okay. This is directed a little bit to Atul Gawande, and it's with a renewed with a new relationship between the States and Cuba. Is there going to be some kind of acceptance that Cuba is doing a huge amount to train people all around the world, medically train them, with very little resources financially, and how much you could accomplish if American financing got behind that training program? Could you speak to that?
It's hard to hazard a guess, except that the door is opening now for the first time after, almost half a century. And I've been to Cuba now enough to see that the primary care infrastructure is pretty extraordinary, and the surgical infrastructure has managed well. They are one of the places that, with Tom Weiser's data, we've recognized as having higher surgical capacity for GDP per capita, and those are exactly the examples of countries that are making transitions that we should be mapping and understanding more deeply.
Good afternoon. So I'm Dr. Ruben Ayala from Operation Smile and the G4 Alliance. First, Atul, really appreciated you taking us into sort of your living room and having us link the numbers with the faces, which is so important. Although I haven't done a tenth of what you've done, I dare use your first name because we're in the living room. And to the panelists, just using that same tone, as part of a civil society organization, and with you being in civil society as well, if we were in a living room and you had two things to say, the answers to two questions, what is the biggest challenge and what is the first thing you would do? What would you say? Ruben, the biggest challenge for us is this, and the first thing you should do is this, as if we were in your living room.
Gentleman at the back here. He's been waiting a long time.
Anybody want to give it a shot?
Stand up and shout.
If I could have an answer, that'd be great, though.
Oh, I thought you were as a statement. Okay.
No,
in that
I
case,
ask questions.
In that case, gentleman at the back can turn his microphone on and be ready.
Hello.
And I'm going to start with Chris.
Education is the biggest challenge.
I was going to say exactly the same thing. Not medical education, education. Is that what you meant?
Yeah.
Absolutely.
Julian.
Money.
Leadership.
Money.
And I'm going to say that it's measurement. The first thing I would do is measure the money and the education and make it apparent that the gaps are there.
You can move next. Thank you. Yes, gentleman at the back.
Working yet? Oh, CJ Foote from the Center of Evidence-Based Orthopedics in McMaster in Canada.
Do you want to speak a little bit louder? I can't hear you that well. Probably everyone else can.
Shout. You sure it's on? CJ Foote from the Center of Evidence-Based Orthopedics at McMaster University in Canada. We conducted one of the studies that's listed in a poster here called the International Orthopedic Multi-Center Fracture Care. What time up? Where we went into India and we recorded 4,500 or enrolled 4,500 patients that had musculoskeletal trauma. And I can tell you that it was an extremely challenging endeavor. And one of the key things that I took home from this is, well, two things and there's some questions that come out of this is, you really need to minimize the amount of data collection you're going to take, because the capacity for research that many of these centers have and the burden, particularly in orthopedic trauma that we saw was, I mean, going into the disaster bays in India, it reminded me of pictures I saw of England during World War II. People are in traction. There's hundreds of people coming to the emergency department daily. It's really quite a catastrophe that's ongoing in many places. So coming from that and knowing that there's a huge burden out there, and how do we get the data out? How do we record the data? I think that this study, this enormous study, is now ongoing, international. The Canadian Research Chair in Canada has now expanded this study out internationally to enroll 60,000 patients within the next 2 years. And the Canadian government has invested almost $5 million in this project. And I think questions we want to know is from your commission, what metrics do you essentially need recorded in terms of open fracture and closed fracture management? Because it seems like there's 3 major areas that we can really impact change. The second question I have is, we really capture data from the urban areas, and as Dr. Gawande stated, much of the neglected trauma that is out there is in the community. And how do we record that data and get that data? Now, there's some suggestions to use the electronic means and whatnot, but I think that's going to be a major challenge going forward.
Thank you very much, CJ, for making that really important point about data. I'm actually not going to let you answer it, team, because our time's nearly up, but I think the point was valid. And we're just having one more question from the lady who's behind me, otherwise I'll get trouble.
No, don't worry. Hi, thank you very much, everybody. I'm not a medic, I'm from the therapy background. I just want to pick up on a point that it's just my view and my impression. You mentioned about Korea managing to improve the global health, but there is a huge divide between North and South Korea. And how is this influential panel here going to overcome the great divide of inequality of healthcare, inequality of poverty, and the human rights issues that are going on between the two countries and other countries in Africa of a similar stature? How are we going to get around that in the grand aim of influencing universal, global, affordable health for everybody?
I'll let others chime in, but what you see is a randomized trial across a divide between once unified country and now a divided country. And what you see is how fundamental economic growth is and democratic strength of a population. We know from data in maternal and child health that there is an enormous link between lack of democratic accountability and survival, and also corruption and survival. And so it speaks to the ways in which I think this report does tie in politically, that when you have countries that are improving economically, there is a pathway to ensure that surgical services are included and that people can progress with that capability as the economies transition. And I think it's very fundamentally important that we show those pathways. But it's also clear that in places that have no democratic foundations and no freedom to allow people to innovate in their own local communities to solve their problems, you have terrible setbacks in the consequences for people's lives.
Thank you, and I'm not going to let anyone else answer that one. It's always nice to end a meeting with more questions, and I'm going to ask the panel to hang around afterwards over the drinks, so please do harangue them then. And a big thank you to all of you. helping us start the very end of where we go next with the Commission. Thank you.
John. All right. Sure. Make yourself comfortable.
You'll be here a while.
Yeah, make yourself comfortable.